Good morning, everyone. Let us deal with the topic endophthalmitis. Endophthalmitis, as the name suggests, end of. So, inflammation of the contents of the eyeball, vitreous, and inner coats of the eye. Based on the location in the eye, involvement of sclera is panophthalmitis. So, how do you classify endophthalmitis? Classification can be classified according to the mode of entry or etiological agent. According to the mode of entry, it could be endogenous or exogenous. Endo, it is inside. So, through the usually hematogenous spread of the organism as a metastatic infection. Structural defect of the eye is not necessary because it is a homogeneous spread inside the body. So, exogenous microorganism directly introduced from environment usually occurs following postoperative endophthalmitis or trauma, or usually exogenous bacterial and endogenous mainly fungal. According to the etiological agents, it could be bacterial, fungal, viral, or parasitic. Exogenous, the major category which contributes for the exogenous endophthalmitis, most commonly it could be postoperative, bleb associated, trauma associated, or metastatic through endogenous or intravitreal injection. So, post-vitreal or intravitreal injection. Risk factors, it could be systemic, local, and intraoperative. Systemic could be diabetes, immunosuppression, steroid therapy, rheumatoid arthritis. The local, it could be a staphylococcal or streptococcal infection of the lids of normal patients, or an nasolacriminal duct obstruction, or conjunctivitis, or contact lens wear user, or prosthesis. Then intraoperative could be prolonged operative time, wound dehiscence, or due to vitreous loss, or irritated lens matter, or contaminated instruments or solution. So, prolonged the prolinival haptics, or a donor cornea, or a traumatic cataract, or depending upon the type of surgery also. So, in postoperative endophthalmitis, so it could be fulminant, acute, chronic. Acute within a week, chronic 4 to 5, more than 4 to 6 weeks. The fulminant usually less than 4 days. Fulminant usually gram negative. So, in acute, most alcohol is negative staphylococcus. In delayed onset, Pseudomonas streptococci could be the most common organism come across. They have presentation of infection usually postoperatively. In normal cases, infection occurs immediate postoperative period. In post-traumatic endophthalmitis, it could be a fulminant, acute, chronic, depending upon the duration. In endogenous endophthalmitis, it could be fungal, bacterial, most commonly Candida albicans, and bacterial Bacillus cereus usually you come across. So mainly you concentrate first and foremost thing to suspect the endophthalmitis. Symptoms and signs are very important for a diagnosis. Usually, what are the end of patients usually come across with the common symptoms? What are the common symptoms? Ocular pain will be severe, blurring and diminution, headache, increased redness, discharge and watering, photophobia, and blepharospasm. So, signs: upper lid edema, marked conjunctival hyphema, intense chemosis, purulent discharge, corneal edema, endothelial precipitates, hypopyon, muddy iris, vitreous haze, absent reflex or an yellow reflex, proptosis, periorbital swelling, low-grade fever, leukocytosis, and severe cases. So, EBS grading, depending upon the appearance of the fundus picture, you can grade 1, all details can be seen, grade 2, second or branches seen, grade 3, major results only can be seen, grade 4, only disc of faintly you can see, grade 5, you don't see any structures, you don't even see the glow. So, fungal endophthalmitis, a chronic infection, rarely acute. Usually fungal infections are slow and progressive, so very rarely you get acute fungal endophthalmitis. Late onset, diminution of vision with the redness and floaters, fixed cheesy hypopyon, fibrinous mesh-like exudates, snowballs and fluffy opacities in the vitreous. So, what are the DDs? Differential diagnosis, post-surgical and non-surgical. It could be a retin secondary to retin intraocular foreign body, iron or a copper, severe past planitis, old vitreous hemorrhage, toxoplasma or a toxocara infection, or nocardia retinoblastoma. What is sterile endophthalmitis? Non-infectious post-operative inflammation. It could be to secondary to retin lens matter or residual chemicals from sterilization or monomer toxicity secondary to PMA or mechanical irritation of the iris or ciliary body by IVL or inadvertent extraocular injection of cyclone. So, what is the main difference between the infection and the inflammation? Inflammation is TOS. What is TOS? Toxic antious segment syndrome. So, in infection, they will have a severe pain and loss of vision. In case of TOS, they will have minimal pain as well as minimal decrease in visual acuity. And when you see the fundus picture, exudates, and in IOP, usually glow is absent in infection. It could be clear in TAS or maybe mild haze may be there. Exudates yellowish in case of infection, whereas in inflammation it is whitish. IOP usually normal in TAS but maybe decreased in infection. And steroid response it worsen in infection but it improves with the TAS. So what you should keep in mind? What are the dictums? Consider all unexpected post-operative infection as infectious unless proved otherwise. Keep high level of suspicion. Do not ignore any post-operative symptom. So why keep it in a mind task? It is mainly due to inadequate cleaning of instrument. So never neglect any case post-operatively. Phacoanaphylactic endophthalmitis. It is an autoimmune process due to lens capsule rupture. Autosensitization due to release of previously sequestered lens proteins. So granulomatous inflammation which surrounds the area of ruptured lens capsule and cortical matters. So how do you investigate for your confirmation of your endophthalmitis case? USG scan to look for any retinal or choroidal detachment, any dislocated lens or any recurrent intraocular foreign body or any parasitic infection. So you need to take a culture by cultural conjunctival swab. Nowadays it is rarely done. And aqueous tap paracentesis with a 27 gauge needle and vitreous tap 0.2 to 0.3 ml. Usually the 23 gauge needle at the pars plana site. You take the vitreous tap. You going to do the culture of the aspirated with aqueous tap or vitreous. So vitreous biopsy, this is how you need to do, and the culture media is used for the diagnosis. Laboratory confirmation of the diagnosis. At least semi-confident growth on solid media. Any growth on more than or equal to 2 media. Growth on 1 media supported by a positive gram string. Newer technique, nested PCR, is to detect, differentiate between the species of gram positive and gram negative organ, improves sensitivity. PCR, RFLP as sensitivity of organism. And you people know now COVID-19 is going on. This machine is having a very important role in diagnosing the corona virus with this PCR RFLP. Now we are using this. And treatment, what are the primary objectives of the treatment? Control and eradicate infection, manage complication, and your main intention is while you are treating, so that you can restore the vision. What are the secondary objectives? Patient should have a symptomatic relief. We should remove pupillary membrane in meiosis, avoid the pupillary block, maintain the globe integrity. So our primary objective is to restore the vision, and next is to symptomatic relief to the patient. So what are the determinants of the duration between the onset and treatment? If it is more than 48 hours, usually it's a poor prognosis. Virulence and organism load. If gram-negative bacteria, usually prognosis is poor. Pharmacokinetic and spectrum of activity of antibiotics is used. Treatment modalities: antimicrobial treatment, corticosteroids, supportive treatment, and vitrectomy. Intravitreal injection, gram positive, usually vancomycin is used. Gram negative, ceftazidime, amikacin, gentamicin usually used. Imipenem. Intravitreal injection, ciprofloxacin, amphotericin B, voriconazole is most commonly used. Intravitreal injection immediately following diagnosis, intravitreal injection should be given. Do not attempt to reattach the syringe to vitreous biopsy needle. In a way, you are again having the infection re-enter. What are the most common complications? Retinal toxicity due to amikacin, macular infarction. So that is the reason you prefer ceftazidime over amikacin. Vancomycin and amikacin possess synergistic bacterial effect if bacillus species are present. So ceftazidime is preferred nowadays, and systemic treatment only an adjuvant. High cost and systemic side effects. Poor penetration into the vitreous. And fungal. Then topical treatment immediately following intravitreal injection on an hourly basis. 2 drug combination, that is vancomycin with amikacin or ceftazidime. Fortified eye drops is prepared and should be instilled every 1 hourly. Subconjunctival injection only if patient not compliant to topical installation, more discomfort, conjunctival tearing or subconjunctival hemorrhage. Then corticosteroid prevent tissue damage by inhibiting release of inflammatory mediators and endotoxin. Supportive treatment, cycloplegics, mean atropine 0.1%. It mainly controls the inflammation and it will relieve the ciliary spasm, and also it prevents the synechiae in meiosis, and dilated pupil helps in assessment and also it helps in better vitrectomy assessment. And anti-glaucoma, oral acetazolamide, topical timolol. So if there is a response to the treatment, it gives your early diagnosis, prompt initiation, and good compliance of that particular case. Vitrectomy. Primary vitrectomy is done for an acute infection. Secondary, if a clear vitreous opacification and membranes are seen, usually in resolved case also vitrectomy is performed. What are the advantages of vitrectomy? It reduces the infection and inflammatory load and provides adequate specimen for a culture. And it is indicated in severe endophthalmitis. Gram-negative organisms are a fungi identified. No response to intravitreal injection. Usually vitrectomy is performed. Role of vitrectomy study in endophthalmitis. If you are interested, please go through this slide. So when you remove the capsular bag, if it is lens bag is totally filled with the pus, and if it is a fungal endophthalmitis and it is recurrence is more common, then usually you tend to remove the capsular bag as well. So in this age you can see this totally cornea is decompensated and total hypopia. So in this case, combined vitrectomy with keratoplasty is usually advised. Endogenous 15% fungal are more common in endogenous endophthalmitis. Organism permeate the blood-ocular barrier by direct invasion or change in the vascular endothelium caused by substrate release during infection. Endogenous endophthalmitis, it is fungal. Even you can come across the bacterial cases also. Candida albicans is the most common fungal infection. Sources would be hepatic abscess, appendicitis, endocarditis, pyoderma, supportive otitis media, pulmonary infection. Risk factors most commonly in immunocompromised and indwelling catheters, major surgery, diabetes, IV drug abuser, organ transplant. So, differential diagnosis of endogenous endophthalmitis, retinitis, acute retinal necrosis, toxoplasmosis, miliary tuberculosis, toxocara, neoplasm. Other investigation CBC with differential cell count, ESR, blood urea nitrogen, serum creatinine, chest X-ray, cardiac ultrasound, CT scan and MRI. And principles of treatment of endogenous: first, eradicate the source. Treat systemically. What is the source for the endogenous infection? First, you have to treat that. Then, vitreous infiltrates, past vitrectomy or antibiotics, and steroids with or without antifungals. The treatment: broad spectrum IV antibiotics, vancomycin, aminoglycoside or cephalosporin, clindamycin or intranasal antibiotics. Then endophthalmitis in children usually post-traumatic, endogenous or contiguous spread. Important to try to at least maintain the shape of the eyeball. Prophylaxis is when preoperatively you take a care, topical 5% protein iodine, frequent installation, double betadine wash, draping of the eyelashes and lid margin will give prophylactic benefit. These are the guidelines. What the measure measures. If you're interested, kindly go through. This is the conclusion you come across. Endophthalmitis as percentage of endophthalmitis has come down. Why? Because of the awareness and measures taken and treatment, availability of treatment, sophisticated better antibiotics, and we need to explain the process once it is case of health. Don't try to raise the expectation of the condition. It should be sight saving. Thank you.